The management and treatment of breast cancer has gotten more complex, and multiple facets to the way that we take care of women today, and it's not what used to be. If a woman was diagnosed with breast cancer, her options were mastectomy or lumpectomy. Now it's a multidisciplinary approach where you bring in experts, breast experts who are in areas of surgery, radiology, pathology, genetics, psychology, and medicine. And as a team, the approach is to give that individualized treatment based on that patient, taking into consideration the family history, the patient's tumor type, her perceptions about risk, and then pull it all together and determine what's the right treatment. So I think that what my colleagues, my message to them is think about this patient getting a team approach rather than an individual approach. It's just one person managing her care. You need a team. There are some treatments that have risks, benefits, there are limitations. An example is breast imaging. I think that when a patient's diagnosed with breast cancer, should all women get an MRI? And if you are going to order a breast MR as part of the workup, who's prepared to discuss the risks, the limitations, the benefits of this technology? That it can cause anxiety, it can lead to unnecessary mastectomies because women fear things are found on the mammogram, on the MRI. So I think that that's one of the things in my field, because I work in the preoperative setting where I counsel women diagnosed with breast cancer, newly diagnosed, as to the next steps. And I take that time to counsel about what is an MRI going to add to your care, what could it cause that could cause more anxiety for you, and extra tests and extra biopsies. So that's kind of one of the things that I think in my field, in the preoperative counseling session, we need to talk about this. And be prepared that there are two sides that patients need to know that too. Is this worthwhile or is this going to complicate my care? I counsel in two areas. I also work in the diagnostic setting. So a woman presents with a lump. That's one of my areas that I am a physician who is got a medicine background, not surgical or radiology, and I am going to pursue the management of the lump. I'm going to decide if she needs additional imaging, does she go to a biopsy, and then when the diagnosis is provided, I'm going to talk to her about the options. Is this pre-cancer or is this cancer? And what do we do now? So we do, we've set up a diagnostic center where the medicine physician is the gatekeeper who decides what other tests you need. Then makes that coordinated approach for the patient that at this point now you're going to proceed to additional imaging and we're going to get a surgeon involved based on this type of pathology and here's what the surgery is going to entail. And then let the patient then hear everything before going to see a surgeon or before going off to an oncologist. We do a lot of that in the education for the patient prior to seeing those specialists. ASBD is exactly what I do. It's the mission of education. And I think that that's one of the things that I appreciate about this society is that it has a multidisciplinary approach with education of both of the patient but also the providers, the healthcare team, and getting out the message. What's the latest in the treatment and what's the quality care we're giving and are we meeting national guidelines? What are the rest of us supposed to be doing? And that's what I think ASBD does very well. Medicine at Mayo Clinic, what we've done is taken an internal medicine focus, trained physicians who are breast experts, breast health experts, and specialists who understand all the different realms so that that patient hears it from the medicine standpoint and then make sure she gets to the right people at the right time. What the surgeon appreciates is the patient is worked up appropriately. All the imaging has been done, the slides have been reviewed, the pathology has been explained to the patient, and they can do their part. what the oncologist appreciates is once the surgery is done and the tumor type is determined, the receptors are known, we can then counsel about the adjuvant therapy. So what they're saying is you prepare the patient in such a way that she's received information at one point in time, and then when she's ready to meet the experts that she's required to see, she is more knowledgeable and then can make a more informed decision. And probably less time spent on the behalf of the experts who shouldn't have to repeat all this because we can do it all at one time. They can see more patients and do a better job providing the care that they're experts at. Surgeons can operate, oncologists can treat. We provide it in such a way that the patient who arrives at 9 o'clock in the morning has, with a complaint, breast lump, can be seen for breast imaging that afternoon. And a radiologist calls me and says, this is the diagnostic, this is what we're seeing, do you want us to go ahead and do the biopsy? Set up the biopsy next morning, and within 2 days we have a path report. I meet with the patient, tell her what's going on, coordinate the surgeon, and the next day she could be in the OR. Just now the patient has been worked up within a week. So what we've done is said, no woman with a lump should have to worry about when am I going to get the mammogram, who's going to call me with the results, when is the biopsy going to be set up, who's going to call me with those results, and I use this term, but that's what it is. In the real world, patients are waiting 2 to 3 weeks for this process. And we hear that having a lump is probably one of the most anxiety-provoking symptoms for a woman. And to expedite that and do it properly so she hears it correctly, and then have a plan ready, which is what these patients say. It's good that not only are you telling me what's going on, you've got a plan. Bring me back, we're going to get an MRI, and you explain all that. You don't just say, an appointment's been made, go do it. But you are the person educating me along the way about why this next step has to happen. So they feel, the patients feel there is somebody taking care of them. Because what they don't want to is show up in a surgical office and say, well, I don't have your records, your doctor didn't send them. Or the radiologist says, well, there's a couple lesions here, we're going to check this one out and this one out. The patient then says, well, when are you going to do it and what is the results of that? And then go, well, go back and talk to your surgeon. The surgeon's out 2 or 3 days because they're operating or whatever, and that's when you need someone like us in a breast diagnostic center coordinating the care and say, go back and talk to her because I'm there every day. The minute they're seen, the coordinated care takes off. And it's in an efficient, timely, with patient education and counseling. I think that's critical. And patients come for that model. We don't go out and market it. That lady tells 2 people who tells 2 people. If you have a lump, go to Mayo Clinic. Or if you have a breast cancer, go there, because they work as a coordinated team and it's pretty clear. Each step of each person's role is identified. It works well. I think more people need to learn of it and have the team buy into it. And remember, in order for this to be successful, the surgeons have to agree that let the physician, the medical physician, the person trained with the medical background, to take the lead, coordinate that, and bring them in. The other thing we can do is preoperative anesthetic clearance, because we're medicine physicians. So we can, check out the blood pressure, make sure her heart disease is addressed, and make sure there's no other issues for her to go to the operating room. So the surgeon says, you already took care of that too.